By the people, for the people, the gathering to get healthcare now, chapter 21, the right solution. The right solution for an IPA is to use the program as stimulus to influence patients to be part of better programs in which healthcare is first, but in which the financial arrangements are acceptable to both the provider and the patient. The IPA becomes the contracting agency for the practices and for the health plans their patients use. The practice and their total patient population becomes a bargaining group to create a system in which healthcare is first, is paid for fairly, there are no wasted services or supplies, and the third-party administration is minimal and cheap. This is the gathering we spoke of in the first part of this book. The capital requirement still exists, but it's helped by the patient contributions and is not governed by the investors who may not be participants in the delivery system and will still be part of the 6 ideas from the 19th century. The amount paid for medical services is dictated by the rates set by CMS, whether paid fee-for-service or capitation. Capitation is just a derivative of fee-for-service experience that is adjusted at the annual budget cycle. The medical group usually agrees to capitation if the amount paid is slightly more than they would have received on a fee-for-service basis. The CMS rate is not viewed as adequate compared to commercial insurers' reimbursement rates and direct payments from patients. So the bonus system is a needed participation incentive. It's probably not an incentive for patient care or coordination of that care, but it's necessary unless you change to a nonprofit public system in which the government pays fairly and has popular support, whatever that means. Special attention to hospitalizations, preventive care by the PCPs, and treatment of chronic medical conditions are the activities that result in better outcomes and lower costs. Physicians do these things if they're working together as a team and have the information about the patients in a timely manner, usually without any idea about the bonus money. Now, since the budget established by CMS in their prescribed rate structure was built on an uncoordinated system of care, a coordinated system of care results in lower cost and better outcomes. The savings creates a surplus from which the health plan can pay bonuses. The budget most often used by the health plan is to assign 85% of the premiums to hospital, pharmacy, and medical pools. Based on audited reports, the 15% assigned to the health plan is about 1/3 surplus. The 85% hospital, pharmacy, and professional pool portion may have a surplus that can be used to fund bonuses for the provider groups. In the final accounting, this is the usual distribution. Administration is 15%, hospital, pharmacy, and medical professional pools 85%. The expected pool expenses for hospital are 40, pharmacy 5, medical professional 30, with a potential surplus of 10. Division of that surplus, you have withholds for reserve 5%, incurred but not reported claims 5%, planned profits 15%, IPA management 10%, capital restoration 20%, specialist 20%, hospitalist 5%, PCPs 20%. That's the normal experiences we've seen in distributions. The division among member providers is based on patient contacts, records of preventive care, and management of chronic cases. In 2003, Congress began increasing reimbursement to Medicare Advantage plans to pass more benefits to patients in the form of prescription drugs and lower out-of-pocket costs. At the same time, Congress also passed many more profits to the participating insurers. The benefits of the former rate increases began to end in 2010 as a 2% decrease followed by a 5% decrease for the next 4 years. These decreases took away the administrative surplus and any other fat that may have been in the Medicare Advantage system. As a result, IPAs in the Medicare Advantage plans that survived needed hospital admission rates of 250 per thousand or less, and the management of chronic diseases had to vastly improve. Business as usual was over by 2015. Bonuses must be earned the hard way by eliminating unnecessary administrative costs while improving patient outcomes. Under the new law, PPACA, the plan profits in the example above must come from its administrative share and not from the medical and hospital pool. The latter must be distributed to the medical care providers as fees and bonuses or returned to the government or the patients. Because the IPAs no longer bear the marketing and sales costs, they may have gained an advantage over the MA plans. If the IPA can maintain hospital admission rates below 250 target, it can make better bonuses because it does not have the higher marketing, sales, and administrative loads.